Thanks so much. So while I'm trying to put my slides, perfect. I would like to thank you for having me with you today. It's a great honor to be with both amazing leaders of the Chinese Society, ISLC, my friend Keishan Zhu and Dr. Yao. I think it's wonderful to be welcomed by you and be able to share my Caucasian European thought about EGFR. What I like here is you are probably the best specialist in the world because you see more of these patients than I do, but I have the chance of being somehow involved in the clinical trials. But it's a discussion because I'm sure you know the topic way better than I do, because you statistically see 5 times more of these patients than I do. But it's a very interesting field, very fast moving. So let's get this excitement together today. So the question is, how should we treat patients with EGFR mutation in 2025? So first thing is my disclosure slide. Then I just wanted to show you how it's difficult to maintain guidelines. This is the ESMO guidelines showing the paradigm of oncogene addiction, with the frontline strategy being not chemotherapy anymore, but targeted therapy. I will come back to that later on, but completely changing the 2000 idea of chemo for everyone. Since 2000 already, probably 2004 for EGFR, the question is how to push the survival boundaries for our patients. We have been writing something which is now still up to date with the group of Fred Hirsch and Federico Capuzzo, Passiane. This Lancer paper showing you again this paradigm of oncogene addiction, with the proportion of this oncogene addiction in the Caucasian and the Asian population, and this secondary on the right conclusion, consequence, telling you that with the exception maybe of KRAS and still of HER2, but it will probably change, the frontline strategy in blue is targeted therapy, is tyrosine kinase inhibitor. So really showing that this is the way to move to push the boundary of survival by definition. If you think about this graph that was built in the past by Passiane, the idea is really to show how the kinase might be modified by EGFR mutations, with 2 mutations which are creating a constitutive activation, but also sensitizing to EGFR TKIs of any generations, the exon 21 and exon 19 alterations, some more atypical alterations, 719 and 861 mutations, but still sensitive to TKI, and the very difficult mutations, the exon 20 insertion, which is constitutively activating but not sensitive to the usual TKIs. So all of this creates this paradigm of kinase domain modification impacting the activity of the molecule. Thinking about the difficulty of keeping up to date a guideline, look at the EGFR box in the ESMO guidelines. Of course, osimertinib is here, but all of the questions we have today, instead of osimertinib, and we will discuss it later on, are still not present in these guidelines. The Mariposa, the FLAURA2. So this is in building. We are doing them again, but it's always difficult because we are moving too fast. And I welcome you. Probably in 3 months from now, we'll have new guidelines, but still it's difficult to follow. So how to push these boundaries of survival? I see 5 options to improve the survival of AGA, actionable genomic alteration, positive non-small cell lung cancer. The first thing comes from the pharma industry and for the laboratories, of course, is to sequence the generations of drugs, to find new generations of drugs with better properties, making the whole result of one drug being better. The second thing is to try to combine the search for the best combination and synergy with, for example, 2 compounds or chemotherapy. The third thing is then to decipher the potential biomarkers, moving into precision oncology. The fourth one is, of course, once you have found the best drug, is to know how to sequence later down the road, 1 line, 2 line, maybe 5 line in EGFR mutations. And last but not least, once you know what is the best drug, you need to move it to early stage disease, because still the best way to impact is to treat early non-small cell lung cancer and not roughly metastatic stage 4. So generation, synergy, biomarkers, sequence, and early disease. So let's move with generation first. It's already the old days. This is the FLAURA trial, comparing osimertinib to erlotinib or gefitinib, improving PFS on the left, improving survival on the right, and having less toxicity because it spares the wild-type EGFR. So basically, all the benefits you can see in a drug. Of course, what is quite important, apart from the better affinity of osimertinib, is the brain properties. It penetrates the CNS way better, making the CNS PFS better, the cumulative risk of having CNS disease progression lower, and of course, the depth of response at the brain level on the bottom better. So not only the numerical duration of survival and PFS, but also the brain activity. And this is not only true for osimertinib, and you know it better than I do because I mainly have osimertinib, but omolertinib, lazertinib, furmonertinib, and befotertinib are very good examples of similar compounds. If you look at the PFS, in exon 19, exon 21, as well as the brain effect, you see that all the drugs compare the same. Two things to keep in mind. In general, exon 19 have a longer PFS than exon 21. This is something that under TKIs is systematically seen. It's predictive, right, of the TKI efficacy, but seen with all of this generation, first, second, third generation. And second thing, which is important, is to keep in mind how amazing is the CNS PFS with these drugs. It's almost the same as the PFS in general. So the brain activities is really optimized today. Okay, so this is drug generations. I don't know which one you have, you'll tell me, but these third generation TKIs are the way to move without any doubt. So now the best question today is how to combine the synergy. So first of all, why would you combine? You're very happy with your osimertinib? No, you're not. Because nearly all patients have very important or cumulative risk factors for mortality. This is the example of Mariposa, but exactly the same in FLAURA2. The patient have a high proportion of these factors, the age, the PS, the brain mets, the liver metastasis, which all of this confer a lower survival. Even if it's some years, it's still not a long-term survival. So keep this in mind. And this is a wonderful retrospective series from Sabari and colleagues looking in Flatiron and many other databases, showing you basically how the survival in the real life, it's real life data, declines over time with only 18% in real life being alive at 5 years. So there's still a big room to improve that in our societies. Why does the disease respond very well and progress later on? So that's still quite of an unknown. I don't know if you remember, but there was the theory, mainly by Raphael Rosel, with this idea that the resistant clone, even if it's 0.001% of the cells, was pre-existing. And under the treatment, it was selected like a Darwinian selection to create resistance. This is the scenario A. But the scenario B started to emerge, that whatever you do, in kind of sanctuaries, right, there are still cells which can continue to survive as persister cell, whatever you do, even if it's not visible on the CT scan. And this cell over time can develop this mechanism of resisting the pressure and acquiring a mechanism of resistance. But the whole duty of these persister cells is to allow the disease to adapt and create resistance. It's probably a mix of both, right? But when you think about combination, the idea is probably to try to make the initial cancer cell death stronger, and if possible, treat the unique vulnerability of these persister cells. If you can do that, you might avoid the phenomenon of resistance emergence, right? And we've been moving a long way since probably 2004, where there was these two competitive groups describing EGFR mutation, so that we were knowing what we were doing with gefitinib and erlotinib, to 2024, when we try to address the problem of persister cells by using combinations. And this is 20 years with lots of developments, but I think really very successful. So let me start to discuss combination and intensification in that setting. So we had osimertinib frontline. This is the FLAURA PFS, 19 months, okay? So now you have all this competition. Of course, we will discuss a lot today about FLAURA2, chemotherapy and osimertinib, Mariposa, which is with the amivantamab, the bispecific MET EGFR antibody with lazertinib, but also the idea in RAMOSE trial to combine with anti-angiogenic. And in the North Star trial, still an idea, it's mainly phase 2, to try to position how much radiation and when should you give radiation to these patients. So I think the anti-angiogenic and radiation remain a question mark, right? Mariposa and FLAURA2 have given us evidence, strong evidence, that combination is better. So let's just start with the anti-angiogenic because I think it's an important topic. On the left-hand side, you have the RAMOS trial, osimertinib and ramucirumab frontline, with a quite amazing improvement in PFS, a hazard ratio very obvious, or 0.6, even a bit lower, but still an immature survival. Remember that with all these anti-angiogenic drugs, the main problem we have at some point is to translate into survival benefit. It might be even that the new compounds like ivonescimab have this difficulty to go into survival impact. But let's keep it in mind. It's interesting, by the way, because the OSIRAM-1 trial, which was presented by a Japanese group some time ago, was not able to show a benefit of ramucirumab. So there might also be some discrepancies between trials, not establishing today that it is the way to move. Okay, so the two trials which build new standard evidences are not these ones, but FLAURA2 and Mariposa. FLAURA2 got FDA and EMA approval. Mariposa is on its way for EMA approval. But basically, these are the two trials frontline which escalate to something which becomes significant. Again, FLAURA2 combining pemetrexed and carboplatin with osimertinib, continuing the pemetrexed later down the road with osimertinib, and the Mariposa combining amivantamab and lazertinib, and continuing, of course, until progression. So let me deep dive into that with you. But before deep diving, let's keep in mind that the main question you have and I have is it really important to escalate in all patients? Knowing that in FLAURA, 1 patient out of 4, or maybe 1 patient out of 3, with osimertinib only, is still controlled at 3 years. So that's a bit of a pity to escalate in this patient, but who are these patients? That's the main problem, okay? So let's move to the data. This is FLAURA on the left, so the osimertinib versus erlotinib, gefitinib. And just for you to look at the curves, on the right, FLAURA2 versus osimertinib, and Mariposa versus osimertinib. Very similar curves, you will agree with me. Hazard ratio 0.67, something like that, and a median PFS of 24 months for Mariposa, 29 months for FLAURA2. So very obviously beneficial strategy and very similar between the two trials. Let me show you the survival because at the end, that's probably what guides us. It's still immature from FLAURA2 with a hazard ratio of 0.75 at the first interim analysis, but the conditional power, which really suggests that it might end up, and it's going to be in some months, only you have to wait a bit, it might end up being positive. And on the right-hand side, the Mariposa shown at the ELCC this year with a survival benefit hazard ratio 0.75 and still not meet in terms of median, but you can see very flat at the end of the curve, right? So this is significant for Mariposa at the final overall survival analysis. So let's go back to my scheme. So look at what we have. We have with a third generation TKI combination, something which looks expanding more or less 6 months on the right. So 6 months longer, probably survival, PFS, or even some more, knowing today that the Mariposa significantly improves survival. Okay, so that's what we have, but at the expense of increased toxicity. Keep it in mind, on the left-hand side, you can see the column of FLAURA2 with mainly chemo-related toxicities. So, of course, blood counts, neutropenia, and the usual chemotherapy, nausea, and GI toxicities that we all know very well. And on the right-hand side, amivantamab and lazertinib with really the EGFR inhibition and MET inhibition toxicities. So it means paronychia, rash, diarrhea, and peripheral edema. So very important to keep it in mind. Specificities are amivantamab and lazertinib, the infusion reactions and the clotting, so the risk of VTEs, venous thromboembolism. So it's quite important to keep in mind that there are some specificities of toxicities. That's the price to pay. If you think about FLAURA2, the main toxicities that you observe, if you look at the timeline, is of course during platinum, where you observe this neutropenia and so on, and it declines over time. Do we really need 4 cycles of induction? How much pemetrexed do we need? Still a question mark. I don't think we have the answer today, and we don't have any prospective data to answer that. This is about the onset also of amivantamab and lazertinib, presented by James Young at the LCC. I was surprised to see that also with amivantamab and lazertinib, the most important toxicity are seen in the first months. Of course, probably with a slight bias of patients discontinuing, but still a phenomenon of habituation or maybe adaptation of the doses, which makes at the end that main toxicities are observed in the first 4 months. But keep in mind that in Mariposa, more or less half of the patient needed dose interruption during these 4 months, during the first 4 months. It didn't impact the progression-free survival, but patients had to stop and resume amivantamab after an interruption of more or less 2 or 3 weeks. So it means that this is something to learn, right? How to manage toxicity of lazertinib and amivantamab. You have to interrupt, you need to potentially change the dose or change the accompanying treatment. So this is not an easy way to move, okay? That's why probably Janssen and Janssen have formulated new strategies to try to minimize the toxicities of amivantamab lazertinib. On the left, the cocoon regimen, which means that you create very early an environment with cream, with nail treatment, with lots of dermatological solutions in order to reduce the rash and all the dermatologic and annexes side effects. And you can see it works, but it's very demanding, right, to put something around the needles. And so it's kind of demanding, but it works. The skipper regimen, which is about creating with dexamethasone less infusion reaction, it also works, but it's a complex one. And of course, prophylactic anticoagulation for 4 months to substantially reduce VTEs. So skin, dexamethasone for infusion, and anticoagulation, a lot of treatments, right, still to prevent that. There might be one easy solution which slowly comes to us, is to give amivantamab subcutaneously in order to reduce the infusion-related reaction. So the infusion, the very frightening reaction. And as you can see on the plot, on the tornado plot, the amivantamab arm subcutaneously has way less infusion reaction, from 66% to 13. So it works very well. However, it's only for the infusion reaction. All the other toxicities, the skin and so on, remains the same. So still something to keep in mind when we speak about these drugs with our patients and with your colleagues. Okay. Third point, biomarkers. Can I choose who are these patients I want to escalate in a biomarker-related perspective? Meaning, can I be predictive with a biomarker of a need of escalation? So to make a long story short, the answer is unfortunately no, because all the groups which usually can stratify your patient population show more or less the same benefits in the Mariposa and in the FLAURA regimen. Hazard ratio around 0.6 in all these categories of brain metastasis, liver metastasis, P53 mutated, or ctDNA positive or negative at baseline. They also benefit. So it's prognostic, of course. It's better not to have brain mets or ctDNA positive at baseline, but the benefit of what you do is the same. So what you use is prognostic factors to know what to escalate and not scientifically relevant predictive factors. If you think, for example, of the example of Mariposa, in Mariposa, you can see this benefit in terms of PFS across all of these subgroups, right? And you will agree with me, very similar. Maybe there's one curve I like, because I'm sure ctDNA will help us in the future to predict treatment, but also to longitudinally follow, meaning that maybe giving holidays and then start it again. So ctDNA at baseline in FLAURA2 was quite interesting because, of course, it was prognostic on the left, but on the right, if you try to see who benefits the most from chemotherapy, both subgroups benefit, as I was telling you before. But you can really feel like that the ctDNA positive, the upper part with a hazard ratio of 0.6, benefits slightly more than the ctDNA negative. It's still not ready to use, right? Because, of course, we need to have more sensitive ctDNA test. But still, it's interesting because for me, that's where I hope more about, right, the ctDNA refinement over time. What is the optimal sequence now? That's a real problem. In all of the trials, this is FLAURA, the main frustration we have is there are lots of patients who do not receive subsequent treatment. Here, 22%, but when you give a TKI, it's quite frustrating to know that some patients have no access to next line. The question is why, how the disease can grow so fast. So again, maybe the more you can sequence treatment, of course, the more you will allow for long-term survival. And there was this nice retrospective study from Robinson and colleagues published last year. We're looking at 2,300 patients and looking if you give osimertinib and then you switch to chemo because you have nothing else, should you continue osimertinib or not? So of course it is retrospective, but looking at all these patients who did continue and the patient who did not continue, it looks like there's probably a benefit to continue osimertinib, right? So maybe a question to ask is if you don't start with FLAURA2, maybe continuing osimertinib when you give chemo later on might also give the same kind of synergistic effect. But of course, this is not a prospective trial. But remember, there was also this Hong Kong data set from Tony Mock and colleagues showing you basically that when you continue with chemotherapy, and it's another theory, what you mainly act on is the brain progression, right? Meaning that what you will protect when you continue the osimertinib with the chemo in the second line is really the brain. So why you do that is to prevent the progression at the CNS level, right? But it's very important for the patient. There are two trials which are ongoing trying to ask this question of after osimertinib, when you give chemo in second line, should you or not continue the osimertinib? All of this trial, of course, asks this for patients who do not mainly have a brain progression because in brain progression, this is obvious that you shouldn't stop osimertinib. But the two trials are asking this question of how much osimertinib is needed in second line. It's very important trials, I must say. Okay, so then you think about sequencing. So we know a little bit about sequencing because we know a little bit about the mechanism of resistance. The on-target mechanism, which means secondary EGFR mutation, and maybe this is C797S or C797X, but most importantly the S, and rare EGFR amplification, right? Representing altogether 13%. Bypass mechanism, sidewalks of the tumor metabolism with MET amplification or some rare alteration of HER2, BRAF, AKT, KRAS can be seen, guiding resistance. MET is very important, 15%. The other are very marginal, 1 or 2%, but still it's good to know because we have targeted therapies. Small cell transformation, roughly 10%, right? Squamous transformation, mainly in Asia, by the way, roughly 10% to 15% too. And lots of unknowns. Unknowns is still half of the patient. We don't know why there is a resistance observed. But we have quite a bit of knowledge, right? So when you think about this being, with the knowledge we have, being shown in another way, I'd like to drive you through these sequencing opportunities. So first of all, thinking about resistance mechanism, we have ctDNA in FLAURA2. And in FLAURA2 by ctDNA, the question is, does it change what I have shown you 2 minutes before? So the answer is no. There are no, I would say, new mechanism of resistance when you give chemo osimertinib, and you still find the same proportions of resistance, C797S, probably small cell transformation as evaluated by RB1 and P53. So something that we knew. So by giving chemo frontline, you don't change the pie I have shown before. With Mariposa, it's slightly different because when you give amivantamab and lazertinib, as you work a lot on MET and on EGFR with a double blockade of EGFR, you have less EGFR and MET-dependent resistance mechanism, as you can see with the chart of MET amplification and EGFR secondary resistance dramatically reduced. That's quite interesting because it also looks like there's a little lower rate of P53 and RB1 loss, meaning that maybe it's still ctDNA, but maybe a little less, at least not more. That was the fear we had, not more small cell transformation. So let me go mechanism by mechanism. When you have EGFR secondary mutation, C797S mainly, So there are new 4th-generation drugs. There probably occasion you use some of them in your center. There are many in Asia being developed with some toxicities. Some had to be discontinued because of toxicity. And very importantly, they need to go to the brain. So that's what is on the pipeline, phase 1, phase 1, 2. And we're eager seeing this data coming because it's a difficult situation, right? But still not evidence-based. Let's look at MET. MET is a long and old story. So the main problem we have with MET is what is MET-driven cancer? And how can you measure MET amplification? Can you measure MET amplification by immunohistochemistry? Probably not. Can you measure it by gene copy number, meaning just counting the number of copy? The threshold is 2, 5, or 10? Good question. Probably it's a surrogate, but you don't know the threshold. Should you use FISH? Yes. It is the gold standard, but no pathologist likes FISH. They don't like to go in a black room to count the copies. But here you have a ratio of 2 as compared to the centromere, of 5 being used. But at the time being, this is the gold standard, but not always used. So it's very difficult to compare the data because most of the trials use a different definition. And with the complexity of antibody drug conjugates, they even use other definition. So this is difficult cutoffs in a small population. But let's look at what we have. The Chrysalis trial was trying in second line and third lines amivantamab and lazertinib in EGFR mutant resistant based on immunohistochemistry. 25% of the cells being MET 3+, okay? And by doing that, in MET positive, the response rate after osimertinib or an EGFR TKI was 60%. So this would be an option, the amivantamab lazertinib Chrysalis 2 trial, the cohort D, after osimertinib in case of MET amplification, here based on immunohistochemistry. But you have way more data. And this is done by Stephanie So at the ALCC meeting. Just look at this table with all the opportunities when you have MET amplification, whatever you use. So first thing, MET TKI alone has limited activity. As you can see in the yellow square, the response rate is between 8 and 30%. So alone, monotherapy is maybe not sufficient. You need to screen a lot of patients to run your trial, right? Look at the screening. It's 1,000 patients to be screened in Savannah, in INSIGHT trial, for example, to be able to give evidence, and it's only a phase 2. So this is a huge effort. Be mindful of the different definition of MET, and this is in green, right, with immunohistochemistry, gene copy number, FISH, all of this being used in this trial. There are fairly comparable efficacy parameters with some CNS activity. Look at the PFS, roughly 6 months, when you use combinations mainly in that disease entities of MET amplification. And last but not least, MET-related peripheral edema is cumbersome, right? Albeit not life-threatening, it's still a very annoying side effect. So that's what we have, right? You can use savolitinib, tepotinib, probably capmatinib, amivantamab, lazertinib with activity, but limited and some side effects, okay? But it clearly works. Let's look for the all-comers. All-comers means these patients where you don't have MET amplification, you don't have C797S, you don't have HER2 mutation or whatever else, you're just a bit deprived from a biomarker. So what can you do? So you can do Mariposa 2. Mariposa 2 is the trial aiming at this patient not having received amivantamab frontline. In second line, you can give amivantamab and lazertinib and chemotherapy. And basically in this trial, the best arm in terms of managing toxicity efficacy was just to use amivantamab and chemotherapy and to drop the lazertinib, which was too toxic. And you can see here's the PFS curve and the interim OS curve. This is a good strategy with a hazard ratio in terms of PFS of 0.48. So you can use amivantamab, lazertinib plus chemo, like the Papillon in exon 20, right, in second line. And this is a good treatment option. Then you can think about the reprogrammation of the tumor microenvironment. It was described in 1997 by David Carbone. The fact that VEGF is an immunosuppressive drug, preventing T-cell trafficking, decreasing PD-L1 expression, increasing Tregs in the microenvironment. So many reasons why VEGF is immunosuppressive. So you can probably use it. This is a crazy table of IO or IO plus anti-VEGF. in non-small cell lung cancer at resistance of EGFR TKI. So you have, first of all, this group with just the checkpoint and chemo, which is negative, but always shows a signal for efficacy, not significant, but a signal. And if you exclude the negative PD-L1, usually they start to be slightly positive, but no new evidence, so you cannot use it. And this other series of trial where, in addition, you have a VEGF inhibitor, right? And in that trial, remember that Empower 150, Atlas, Orion 31, and Harmony A are all positive trials for PFS at the time being. So showing that here, this is a strategy that you can follow: chemotherapy, platinum, pemetrexed, an anti-PD-1 or anti-PD-L1, and a VEGF inhibitor. So some things that to keep in mind. I just wanted to show you the Harmony study because it's the latest one we have been seeing, the ivonescimab bispecific VEGF PD-1 with chemo versus chemo at progression under EGFR TKI, where you can see on the left, the PFS curve is kind of amazing, right? You can really see the difference. So it might be a good option, chemo, anti-VEGF, anti-PD-1. Okay, we'll see later on. And then you have these ADCs. So lots of ADCs in lung cancer development. Some are approved, but what about EGFR mutated? So the EGFR mutated, they have activities in second, third, fourth line. So this is, for example, the datopotamab deruxtecan, 43% response rate, PFS 6 months. So patritumab deruxtecan targeting HER3. Sorry, datopotamab deruxtecan is targeting TROP2. Patritumab deruxtecan targeting HER3. 30% response rate, PFS 6 months. And in the DESTINY-Lung03, targeting HER2, in these patients who have a HER2 overexpression at resistance, amazing 70% response rate, 8-month PFS. So these ADC work well at resistance to TKI. There are even some new drugs, right? We have some combination of the MET ADC Teliso-V with osimertinib, 60% response rate. This ADC targeting EGFR and HER3, the BLB01D1 response rate, 67%. Or the new TROP2 ADC from now Merck, 60% response rate. So they work. And they work probably better than in non-mutated in wild-type EGFR. So it's probably a better drug for EGFR mutations. Remember about the Teliso-V, that at least as monotherapy, it might be replaced, the Teliso-Vedotin, by the Teliso-Adisutecan, which is way more effective, at least in all comers. So we have already a new generation of MET-targeting ADC produced by AbbVie. So this is a graph of what we have today, response rate, PFS, and OS. So all of these ADC work quite well in second line and third line. I would say probably as well as platinum doublet, yes, in terms of duration and response rate. There are some ongoing trials like phase 3. So for example, the patritumab deruxtecan versus platinum doublet. You also have this TROPION-Lung15 when you have datopotamab deruxtecan plus osimertinib versus platinum doublet. And you have some other ongoing trial with the new, for example, TROP2 ADC by Merck. But keep in mind that for the HERTHENA-Lung02, so patritumab deruxtecan versus platinum doublet phase 3, this has completed accrual. This was the design, right? Patients after one or prior lines of EGFR TKI, patritumab versus chemotherapy, primary endpoint PFS, and remember the press release. It is positive, but it's already a long time ago, September 2024. And we'll see the data at ASCO later down the road this year. This might completely change the paradigm, and at least it will offer us a new treatment opportunity. Maybe the last slide I'd like to show. Probably it's the most difficult for you too. It's a small cell transformation, right? This is a drama. This is on the right-hand side, just look at the survival. This is not PFS, it's survival. What's the survival of this patient who have a small cell transformation in EGFR mutations? So this looks like the worst curves you've been seeing in your life. That's true. Patients progress and die. So the transformation occurs in 10-15% of the patients, right? The median time to transformation is 17 months from the diagnosis, right? They have a poor prognosis. Median overall survival is 11 months. It's interesting because small cell retain EGFR mutation. If you had a T790M, usually it disappears. showing that it's another clone outgrowing. There's unfortunately no evidence that you should continue osimertinib when you give platinum etoposide. It doesn't change anything, so just go with your chemo because osi doesn't add anything. And unfortunately, there is a nice small trial from Korea trying to combine osimertinib, platinum, and etoposide initially in these patients with a pre-existing p53 mutation at initial diagnosis. So instead of giving osimertinib, you immediately give osimertinib and chemo, and it does not prevent the small cell transformation. So nothing really to do in this situation, right? And I will be happy to hear what you do because I'm a bit desperate and I have some of these patients in my clinic. Late lines, this is what you have. And you will agree with me. If you use chemo IO, if you use Chrysalis trial, if you use ADC, you have the same consistent semester of PFS, 6 months, survival of 1 to 2 years, and response rate of 50%, 40 to 40. So kind of nice opportunities and maybe lots of sequences which are possible. Let's go back to frontline strategy. Plaura 2, Mariposa. This is the slide from Jordi Raymond. So it's very difficult to know, and it's only evidence-based data of what is the best way to start to have the longest survival. We need more follow-up to see how you can sequence these drugs to see if at the end it really makes a difference. But that's what we have today, with probably with the cost of toxicity, slightly longer survivals when you start with combinations. But of course, you need to think about the brain, the toxicity, the economic impact. Of course, for amivantamab, it would be better to have subcutaneous infusion to avoid the nursing problem. And of course, it will take you half an hour, but you need to discuss it with the patient. Does he just want a pill, or does he want to come to the hospital every 2, 3, or 4 weeks, depending on what you do? So it's quite important to have this discussion. All this being known, I told you in the beginning, you need to move to early disease. We have done it with neoadjuvant perioperative IO, but we also have done it in oncogene addiction, in ALK and in EGFR. So this is the immunotherapy, but remember that with EGFR, you have this amazing ADAURA trial. This is the DFS in stage 2 and 3A, primary endpoint, and the ITT population on the right. And this is the survival, 5 years overall survival rate, hazard ratio for death 0.5. So now in all patients with tumor more than 3 centimeters and later down the road, there is a rationale to give probably chemo when needed, but more importantly, to give osimertinib for a final duration today of 3 years as much as possible. So better pharmacological properties, we have them. Biomarkers, we don't have them. The synergy, we have it, but we don't know when to use. The optimal sequence, too many, we don't know how to do it. Still a little mess, you will agree with me. And of course, if you can move to the ADAURA trial, if you can move to the early setting, you have benefited your patient the most. And with this, I thank you for your wonderful attention.